Yes, I have today.
Welcome, everyone, and thank you so much for joining us today. This is our second webinar in this series. I'm going to go over just a few house rules for today, and then I'll introduce our speaker, Dr. Bhakti Hansoti. So for all of you who have joined us today, this is a series, and we're trying to cover a wide depth and breadth of topics throughout this series. So we're hosting them every Tuesday and Thursday, right now at 9 a.m. Eastern Standard Time, though we might have a change next week. Our next one is going to be this Thursday at 9 a.m. Eastern Standard Time, and we'll be discussing therapeutics on that call. If you have any questions, please add them to the chat box. We tried to make this pretty succinct at a 30-minute session so that you all can get back to your very, very busy lives. But we are going to work to answer any questions that you have, compile them, and post them onto a resource page that is forthcoming. So please do make sure that you add your questions to the chat. If we have time at the end of this presentation for Q&A, then we'll also discuss as well. So today we are going to be hearing from Dr. Bhakti Hansoti about screening, triage, and patient flow. Bhakti is an associate professor of medicine at the School of Medicine at the Johns Hopkins School of Medicine. She holds a joint appointment at the School of Public Health in the Department of International Health, and she is also an associate director of the Center for Global Health, which is helping to host this wonderful series. So Bhakti, I'll turn it over to you. You can share the news and share your talk, and we're all excited to hear from you today.
Thank you, Anna. So I'm going to start with a disclaimer. I'm COVID positive. I'm on day 3 of illness, somewhat dyspneic. So I'm going to be taking lots of pauses, which hopefully will just improve the cadence of the talk. So I apologize, but I felt that I was getting so many phone calls about this topic as a number of you are getting your departments ready. I felt that it was really important for me to still give this presentation. As I said, if I run out of steam, we will still have a resources page available, and I'll answer as many questions as I can. And you'll get a real life example of hypoxia. Right now, my pulse ox is around 97 and I'm tachy to like 110. And we'll see how it goes as we get through the talk. But it'll be a real life demonstration of life with COVID. So without further ado, so I do want to cover a lot of different things here. I want to talk about the clinical features, and I know this is a little repetitive from last week, but I just want to get us on the same page, especially for the newer participants who have not been a part of the series before. I then want to talk about the emergency department or the healthcare facility that you are working at and how to prepare that department. The initial management approach to these patients, and I'm really going to talk about triage, screening, and severity. And then other management considerations, which I'm going to touch on very lightly because they were covered in depth in the previous talk and will be covered on Thursday as well. And I'll take some questions at the end. So I wish we had a live O2 sat monitor, and then you'll see that it drops when I speak. And those of you who know me attest that I have a much better sounding voice when I'm not sick. So this COVID disease, how contagious is it? Because as emergency physicians, we think about this disease context based on our previous experience to decide how to prepare our department and understand our level of risk. So COVID currently has an R naught of 2 to 3.1, which means for every index case, 2.5 to 3 people will probably catch the disease. You know, I put down like what measles has. So measles 11 to 18, HIV is 3.6 to 3.7. So you're like, huh, you know, that's less than I thought, right? The challenge with COVID versus those other diseases is that we have strategies to prevent them, right? So with HIV, barrier protection, PrEP. With measles, we have vaccination programs. The other challenge is the modes of transmission of this disease and the severity of illness. So if you look at this, which talks about the average number of people infected and the fatality rate, whilst the average number of people infected doesn't seem that bad, the fatality rate is high up there, getting closer to SARS and MERS. The other challenge with this R0 was that it was calculated pretty early on in the pandemic. None of the countries had adequate testing. We quickly transitioned from an outbreak to an epidemic to a pandemic, which means contact tracing is extremely challenging. And to really understand an R0, you need great, phenomenal epidemiologic surveillance with contact tracing, with universal testing capabilities, and we just haven't had that ability. So how is it transmitted? 3 forms, right? And you think about this when you think about your healthcare workers, and you think about this when you're preparing your department. Close contact, which is why we have this 6 feet distance recommended. Airborne, so when you're speaking in a room, it's likely that the particles are aerosolized and they stay in the atmosphere about 3 to 4 hours. And then fomites, when the particles go into the air and land on a surface, they may last there for at least several hours, if not days. So it's a challenging disease to contain. I'm currently contained within my bedroom. This is my airspace. No one comes in. I don't go out. We don't share any utensils. And the reason for doing that is to try and protect my family. But when you think about an emergency department and the flow of an emergency department and how people go between areas, you know, with or without barrier protection, and when we keep our barrier protection, our PPE on, and whether it's just during patient contact, that helps us with close contact, but may not protect us from airborne or fomite transmission. How do people present? I'm 17 weeks pregnant, add to the complication here. I initially just started vomiting, and then I had a headache and a low-grade fever. I'm day 3 or 4 right now, and I'm dyspneic with a cough. But you know, initial thoughts are fever, cough, extreme fatigue, which I can attest to. A lot of people have reported these GI symptoms, and then a headache. And I have to say the headache was what made me get tested. It was unusual and peculiar and unlike a headache I've had before. As I alluded to before, the challenge with COVID is that the people that get sick really get sick. So most people with COVID-19 are mild or uncomplicated. We actually believe that 25% of individuals are asymptomatic. 14% develop severe disease requiring hospitalization. And this is not restricted to the elderly. While the mortality is higher in the elderly, it's a disease of all ages, and we do have young patients in the ICU or in the emergency department or the wards that are sick. 5% require admission to an intensive care unit, and the outcomes post-intubation have been somewhat mixed. Anecdotally at Hopkins, our outcomes have been quite promising. You know, our mortality rates less than 20%, but we've also seen accounts from Italy and New York where mortality for intubated patients has been greater than 50%. The reason is for those people who get really sick, their clinical course is complicated by acute respiratory distress syndrome, septic shock, and then multi-organ failure. And the reason for that is a phenomenon called the cytokine storm. So we believe in the early phase of the infection, it's a viral response phase, you know, it's kind of where I'm sitting right now. You know, I feel yucky, feel I'm sick, but it's somewhat manageable. And the hyperinflammatory phase, We see a rise in IL-6, D-dimer, fibrin degradation products. So these surrogate markers of an acute, severe inflammatory response. And it's those markers that lead to your shock, ARDS, and multi-organ failure. I just want to go back to the age and demographics of these individuals. So as you see with the chart on the top left, young people do get this, right? So between 30 and 60, they make up 2/3 of your patient population. And since I'm in that age group, that does not make me feel happy. But if you look at deaths, it is true that the deaths are going to be in your patients above the age of 60, and that death increases exponentially as you get older. What does that mean for your department? You're going to see young people. You're going to admit young people. Your demographics are going to change. But hopefully, these people can be treated. For those of you in low resource settings, which I think is a majority of this audience right now, if you look at the composition on the top, that shows you the population density for Italy and Republic of Korea. Now, that same population density map was applied to Brazil and Nigeria, which is on the bottom, and they have a much lower proportion of younger patients. And as you can see, that their relative mortality, right, the relative volume mortality decreases. So there is some hope, and it's not incorrect, that countries that have less of an aging population will likely see lower overall mortality amongst their population. So now we've got this frame, right, of mixed bag of symptoms, sick or really sick. There are some young people. Let's talk about preparing the department. Because as I know, most of you are doctors, but when you wear your doctor hat, you're also a medical director, an advisor to the Ministry of Health, and an academician and a researcher. And so we're here to support all of those multiple hats that you wear. So I found this to be the best resource to take a really pragmatic approach in considering how do you prepare your department. So this is a checklist produced by the ECDC, and it allows you to think through, like, who should your core team be? Who are your internal, external contacts? What is your staffing structure? So if you look at a lot of the ICU data, we talk about pyramid staffing. In my hospital, and we'll talk about split flow in a second, we have radically changed our staffing structure to create these discrete pods and teams to decrease the amount of contamination amongst clinical areas. How do you communicate, right? So in a critical care resource room, when people are wearing PAPRs, and it's already a complicated situation when you're dealing with a cardiac arrest, how do you communicate? Well, it's extremely difficult, and there is miscommunication. And so we bought some very cheap walkie-talkies, which seems to work, and had designated comms people inside the room and outside the room. Simple things such as whiteboards have been really effective on the doors, or even writing on the glass window. Hand hygiene, like how many washing stations, what is your stockpile of PPE? I'm going to talk about PPE in a second. What is your management plan for the PPE? Your triage strategy, how do you move patients? And also, as I mentioned, the virus lingers, and so environmental cleaning has a key role in keeping our departments, our healthcare workforce safe. Another great resource, so this is from Cerner, and this will be made available to everybody. Here, they advocate for the split flow. So essentially, you're dividing your department into two. You have the non-ILI, so non-influenza-like illness, non-person under investigation, the two terminologies that we'll use, and then the ILI, PUI kind of person. I'll talk through screening in just a second. The whole department is divided, including your critical care areas, your urgent care areas, and your booking. because you are likely to have all three categories of patients in both different sides of the ER. When you think about split flow and you think about how to manage this, what you want to do is come up with a patient flow structure that's simple, easy to follow, and decreases the chance of mixing. Also, I would say that it's better to have more people in the PUI group than it is to have them in the non-ILI group, because the non-ILI group is where your cancers, your immunocompromised, your sickle cell disease, your unstable heart attacks are all going to be. So if they get exposed, then they will end up with a secondary illness on top of the illness that they're presenting with. So in our split flow, I'll talk through this very quickly, but I advise that you go through Cerner and then adapt this for your own department. You initially, when the patient arrives, do they need resuscitation? Everybody who gets resuscitated who cannot give you a history needs to be a PUI or an ILI until proven otherwise. That includes the GSW to the neck that I intubated the other day. I did it with a paparon. Once, if they can give you a history, then if they do have ILI symptoms, put them in a mask and then send them to a separate triage area where you can decide whether they need to go into the emergency department or can be taken care of in a tent or an outside facility and be managed that way. Those people that have none of the symptoms, and I'll go through some tools for screening, can go directly to the ED and go through the traditional triage process that you have. I get a lot of questions about PPE. And so this is what we try and do at Hopkins. We have an N95. Instead of the goggles, we all wear visors. And the reason we're wearing a visor is it stops moisture or droplets from contaminating your mask. Gown and gloves. That is for all PUI patients or all ILI patients. I will say, if you can stop your cameras, everybody, that would be great, just to preserve our bandwidth. For non-ILI or non-PUI patients, the current recommendation is a surgical mask. But I'm going to talk about my own personal feelings without evidence on what we should be doing in the rest of the emergency department. And I worry about how I got sick, and I'll explain my thought process in a second. We are reusing N95s and visors. So I use my equipment throughout my whole shift. And then when I'm done, I put it in a brown paper bag and I come back to it the next day. And if my mask is dirty, I go to the charge nurse, show my dirty mask or my contaminated mask, and I'm given a new mask. Early rationing will help your stockpiles, but it also will decrease healthcare worker frustration, because the challenge with COVID-19 has always been the moving and dynamic guidelines and policies as the pandemic evolves. So taking a forward-thinking strategy that optimizes your resources will likely have the best success. In this preparedness phase, everybody needs to know how to don and doff safely, because it's not just for the individual who is seeing the patient, it's who that individual is going to interact with afterwards. So this is how I got tested. I got tested in a car. The person didn't have to see me, didn't have to be in direct contact. And I think it was a great strategy that we've been able to adopt here, is drive-through testing. But because I know I'll get questions, I'm going to talk about what happens when a healthcare worker gets sick. So I got sick. I worked last Thursday, Friday, Saturday, Sunday, Monday. And then I got sick on Thursday. So I probably, other than going to my clinical shifts, I've had no outside contact. I haven't been to the grocery store or the bank. I haven't got anybody coming into my house. So it's likely I got sick in the hospital setting. I retraced my steps. Every patient, I wore an N95. I wore my PPE. I think it's a numbers game, right? Some of us are going to get sick. I happen to be one of those, some of us. I'm also pregnant and relatively immunocompromised, so to speak, so maybe a little bit more vulnerable than the rest of my colleagues. My pregnancy should help with the lack of a cytokine storm, so we're being hopeful that I don't progress too much. But I think what happens in the healthcare setting is that when we see a patient, we put on all of our PPE, and then we interact in the hallway or in a meeting, and that mask comes off or that PPE comes off, or we get a little bit closer than we would like. And I think my new thinking on this is that perhaps I should have kept my PPE on the whole time I was in the department. Well, I did put a surgical mask on from the minute I walked to my car to my department and throughout the department. I wonder if I should have had an N95 on for the whole day, and then there's just really less chance of me contaminating my N95 and not maintaining the integrity of my N95. I'm sick at home, pregnant, monitoring my oxygenation. And as I said at the start of this, we'll see where I'm at right now because I'm a bit breathless. I'm tachy to like 110s. I'm hypoxic. If I walk, my sats drop to 92, 90. I'm hopefully going to get home oxygen later on today. I'm doing better, 96 because I've been sitting, and heart rate of 100. My husband is an ICU doctor and is spending 7 days caring for COVID patients. So when you get sick, you need a plan, and we had a plan. We knew we were going to get sick, one of us. So we wrote our wills 2 weeks ago. My mom has been staying with us. We had a quarantine plan, as in if one of us gets sick, who gets the bedroom, who gets the guest room, where are we going to shower, how are our lives going to be divided, what is our communication strategy to our daughter. I have a 2.5-year-old. I spent the last 2 days in tears because yesterday my daughter tried to climb a drain pipe outside my house so she could get to my bedroom. It is heartbreaking, but this is what we signed up to do. So we're going to get through this and be really tough. But think about these things as you're preparing your own departments and your own families for what is a terrifying, unpredictable illness. So switching gears, let's go to initial management. And it's true, we go to work, we need our friends and our families to stay at home for us. But the truth is, patients do get sick, and we are seeing numbers that I never imagined in a lifetime. I've stopped looking at the ArcGIS COVID-19 data because 700,000 does not compute anymore. A lot of what I'm going to talk to you about is through the African Federation of Emergency Medicine. I do have a fondness for AFEM, and I've worked closely with the leaders of this group. But one of my main reasons for doing this is that their tools are designed for low resource settings. They're easy to interpret at the healthcare worker, at the basic healthcare worker level, and they're extremely thoughtful and simple. If you want more information, you can email them or go to their website. Again, I'll have all the tools available on the resource page. So Triage is the hallmark of clinical management in emergency medicine, right? Early recognition, early resuscitation, early stabilization. That is what we do. And I want to expand your thinking slightly for this pandemic. I want to add in the nuances of screening before triage, and then post-triage severity scoring and what the utility of that is. So as I said, the goal is to keep your non-PUIs and your PUIs, or your non-ILIs and your ILIs, separate. So screening is that first thing that you do. My PhD was in SCREEN, Sick Children Require Emergency Evaluation Now, which is a tool that's used throughout Cape Town in primary healthcare clinics. But we designed a simple tool that the guard or the extended public health worker could administer at the gate of the clinic. And that allows to have 2 patient flows right from the get-go. And I'll show you the tool that I think I suggest. Triage is for you to understand now, once they're along this patient stream, what level of care do they need? The South African triage tool is great because it uses vital signs. And I think I'll talk about silent hypoxemia, but having vital signs is crucial in these patients because so many are young and look better than their numbers will look. And so it tells you who needs to go into the hospital or who's hemodynamically stable, walking well, that can be managed in a tent or an outside facility, so they never come into the facility. But those who are then sick, you can use a severity scoring tool, which I'll talk about. But that severity of scoring tool is maybe a trigger for transfer, a trigger for level of care. When you have so many providers, and many of you will end up using providers who are not emergency medicine trained or who do not have experience in the emergency department, having an objective measure to prioritize patients is probably invaluable. It does not replace your clinical decision making, and it doesn't really guide your management because your history and exam should do that. So screening tools, the WHO, one is on the left of your screen. Theirs is flu-like symptoms, but also some contact tracing questions, history of travel. My challenge with this is that it is subjective, it is long, and it's difficult to remember all the questions. And I'm not convinced a lay individual would find this easy to administer. I also worry that this was written when we were dealing with outbreaks, right? Isolated, small numbers of cases. We're dealing with a pandemic, which means we know there's community transmission. And you may, I don't know, I can't name a single person that I was in contact with that had ILI symptoms where I didn't wear PPE. Yet I'm sick. So I must have been in contact with an asymptomatic carrier during my clinical shift. The Hopkins, this is what we do at Hopkins. Again, it's not a gold standard. It was based on, our best practice. And we will put anybody who has fever or shortness of breath or cough or muscle aches or loss of smell, and headache actually is in there too, as an ILI. And then when they get to that triage stage and get seen by a healthcare professional, they may come back to the non-ILI side. But our goal is to be very, very, very sensitive. Once we have finished screening and they've gone to the flows, and they get to a healthcare work evaluation, which means either a senior either a senior nurse or a junior doctor. And we want a set of vital signs. And then they categorize patients between red, yellow, and green, which allows people to determine whether they're walking well, need some intervention, but can be stabilized. So those would be your cases of pneumonia, so higher respiratory rate, lower O2 saturations, they'll probably need oxygenation. You may want to do a chest x-ray. And those who are critically ill, those people who have had the cytokine storm, may have septic shock or acute respiratory distress syndrome. And those people need aggressive resuscitation, but maybe will require transfer to a higher level of care. This is the scoring tool, which again is similar to the triage strategy, but includes comorbidities as well, because as we know, people with one or more comorbidities, and as the number of comorbidities increases, your likelihood of death also increases. There is an app here through SurgiSphere, which is open access and easily available. As I said, this tool should be a trigger for levels of admission or transfer, but maybe not for guiding your decision-making. Clinical management, that should be guided by the patient's symptoms, your examination, and your clinical management gestalt. Mild patients really don't require much. Self-quarantine is the most important things you need to counsel them about. Those are moderate symptoms, such as myself, who will probably require, can still probably go home, but need self-quarantine with some monitoring. So these are invaluable. We do not recommend systemic steroids. We know that the shorter breath, the systemic steroids have shown poorer outcomes. and they need very strict return precautions. The trajectory is unpredictable. So I usually have someone every 2 hours knocking on my door checking that I'm okay, because I can tell you from hour to hour, I'm good and then I'm bad and I'm good. And I think we know that people decline quickly. Those with severe illness are likely need supplemental oxygen therapy, maybe resuscitation, maybe antipyretics. And those that are critically unwell, I strongly recommend you go back to last week's talk, which is available on our website, where they discuss the critical management of these patients. What do these people die from? Actually, before I go, if people want to talk about testing and how that links in with patient flow, let's do it in the QA at the end, okay? Because I think there's going to be testing and triage and how they connect a little bit later on. So what do they die from? They die from acute hypoxic respiratory failure. It's a silent hypoxemia. So my husband jokes, he's like, you're the example of a happy hypoxic, which sounds like a very endearing term. What it means is that when I'm winded, my SATs are sitting around 89, 92, which is obviously not great because I'm pregnant, and that means there's a relative hypoxia to the fetus, which is why I think today we need to find some oxygen, or I need to go in. What is the SpO2 target? This is for, the WHO recommends 94%. But if you look at the Rebel EM website and also some of the new literature or opinion pieces, and like I say this, the literature out there is awful. There's a lot of opinion pieces. If you look at some of the new opinion pieces, you know, a pragmatic approach of hypoxia between 88 to 92% is probably adequate. What you need to be monitoring is the patient's mental status. So you'll see all these tweets of patients who are on their bellies, texting away, SATs of 85%. Remember, these are young people, and I know proning is extremely effective. So after this, I'll prone for a couple of hours, my SATs will go back up, I will feel much better. Intubation strategies, again, go back to Will and Adi Hedete-Casarbalda's talk from last week. But we're recommending pre-oxygenation. We're not recommending back valve masks due to the aerosolization of the procedure. A rapid sequence intubation strategy is ideal. And then the use of fiber optic or video assisted intubation to maintain the distance between the patient and the provider is key. I put this picture up to show you the box, and it's been one of those things that's in the news and everybody's buzzing about. Two things. One, this gentleman needs to wear PPE. The box does not protect you because the box comes off and everything gets aerosolized, right? So there's no excuse for not wearing PPE. The challenge with the box is I think it's effective if you're in a negative pressure environment, so that you finish your intubation, the box comes off, all of the aerosolized virus goes away, right? But if you're in a closed area, all you've done is concentrate the virus. The minute the box goes off, it just sticks around. Post-intubation, there's a paper by Gattinoni, which is also available on our website, talks about these two types of COVID ARDS. So there's two pathophysiologies here. There's classic acute respiratory distress syndrome, where the patients have low lung compliance due to the fluid and the protein in the lungs, and they do benefit from PEEP. The challenge is that a higher number of patients also have high lung compliance. They have good lungs. So that same 5 cc's of PEEP will rapidly expand their lungs, increase intrathoracic pressure, and can have negative consequences such as barotrauma by causing a pneumothorax, or can decrease your cardiac output, because at really high, when you have great intrathoracic pressure, you can cause a compression of the pulmonary vasculature. Read Gattinoni's paper, it'll change your management. I will say the way to distinguish between high compliance and low compliance lungs is to look at the plateau pressures. If you don't have that available to you, then go low and go steady, and talk to critical care early. If this patient is not behaving on that ventilator as you expect, then you need to get help with someone that really understands pulmonary physiology and vent mechanics to make sure you're safe. If a patient who's doing okay suddenly desats, then consider pneumothorax and barotrauma in your differential and get a chest x-ray or do a point of care ultrasound early. I'm going over a little bit, so I'm going to spend 2 more minutes to talk through a couple of management strategies, and then we'll go to questions. So CT scan is sensitive, but it's not relatively readily available. Ultrasound has been shown to be useful, and I think in low resource settings, many of you have phenomenal ultrasound skills. There is like good images available on what you should expect to see. And this shows comparison between lung CT findings and lung ultrasound. Diagnosis is not based on imaging, it is based on the clinical case. But it can show you the extent of pulmonary involvement, and it can help you rule out other differentials. 3 other things for you to watch. Again, I think we're going to hear more and more about these, but as you prepare your departments and you're preparing your clinical management guidelines, patients do have a lot of bronchospasm. You've seen I've been coughing throughout this talk. That causes them to desat. 2 strategies that have been helpful. So yesterday I started Montelukast, limited evidence, effective in Zika and H1N5, but I did feel a little bit better, relatively low harm. Inhaled steroids, maybe through a spacer such as Flovent, have also been effective in decreasing bronchospasm. The second thing is blood clots. So people are documenting that these are hypercoagulable states. There are clinical management protocols that are advocating for low dose molecular heparin. The last is we know that the COVID virus does cross the blood-brain barrier, and these patients are notoriously difficult to sedate and chew through sedation. So when you think about your sedation strategies, you really have to take stock as to what you have. I think a lot of us are running out of propofol and fentanyl due to the high sedation needs of these patients. Strategies such as ketamine, methadone, are now being used as well. But if you can decrease the bronchospasm on the vent, you probably can get away with a little less sedation because the patient's going to be less agitated. I need to breathe. But these kids do a great job of social distancing. It just makes me smile looking at this picture.
Bhakti, maybe I can give you a second to breathe and go over a couple of questions, or would you like to summarize first?
So I think I can skip the summary. It's pretty obvious. I've mentioned it a couple of times. I just want to say thank you to Megan Harrison and Daniela Amdusen for helping with the slides and the resource page, and the St. Hopkins Center for Global Health for putting together this series. And we'll go back to the happy picture and take some questions.
Okay, I've tried to get a set of groupings of questions. Some of them might be more comments than questions, but there were some questions around how many of the resources and recommendations that you went over today might not be available in low resource settings, and so I wonder if you might be able to comment a little bit on that for the people who have joined us.
So I think the majority of my recommendations around triage, screening, and split flow, those are available for clinic level facilities as well as your tertiary care facility. I've been consulting my colleagues in Port Elizabeth. So I work at Livingston Hospital in South Africa quite frequently, and then a couple of other institutions in the Eastern Cape. And we can't get a tent, right? So what they're doing is setting up chairs and the awnings with big umbrellas, and those are their triage flows. You have to think creatively. Yes, intubation may or may not be available, but if you do have intubation, I think it is worth mentioning the 2 phenotypes. Prior to intubation, though, Dr. Checkley and Dr. Casarbarda go through this, but there is strategies to optimize your patients. So supplemental oxygen through a nasal cannula, oxymizers available. They work with oxygen tanks, which are a good intermediate step to high flow oxygen. Patient proning, that's just putting them on their bellies and having a protocol and a strategy to do that and to monitor the types of patients that can be safely proned. The majority of management of these patients is supportive.
There were also some questions about stigma. So people coming in and denying certain symptoms, which was making triage a challenge. And I think this was this came up in the setting of Bangladesh, but I'm sure that we're seeing that in other places as well. So what recommendations might you have if patients are sort of refusing to discuss or disclose some of these symptoms?
The stigma is challenging. I think many of the individuals on this presentation will have also experienced HIV positive population and the stigma around disclosure for positive HIV. I think there's some really simple strategies that could be adopted. One is like really clear and concise messaging, either by having a nurse going out into the waiting room or posters at your healthcare facility saying, this is to keep you safe and your family safe, right? So if you can help us, we can help you. And I think that reinforcement constantly that having a symptom will not negatively impact you, but that it will allow us to correctly diagnose you and manage you, and then give you the correct information so you can then keep your family safe. I think you have to have multiple touch points with patients. So you have the screening at the front, but when you triage, you need to re-ask those symptoms. When you finish your history and exam, you also need to re-ask and re-ascertain ILI symptoms. And I think that by that continuous routinization of the questions, that will normalize the process for them, but it will increase your likelihood of disclosure.
Luana had two questions that I think are quite relevant to these issues of screening and triage. So one is the tool that you shared focuses on the most prevalent presentations with respiratory symptoms, but what about those who might have more atypical presentation? And then her first question, so I think you can do both of them, was about downgrading patients. So moving patients who are in the ICU back to the wards. So I'll just give both of those to you and let you take them.
Right. So because of the atypical presentation, that's why we have a screening tool that includes all of those symptoms, like such as headache and GI symptoms. What we find is that when you do vital signs, so the cause of mortality is acute hypoxic respiratory failure. So no matter what symptoms they come in with, when you do vital signs, you're likely to identify that these patients are hypoxic, right? And so it's the hypoxia you need to intervene upon. Even if they have atypical symptoms, if they're hemodynamically stable, then the messaging should be, you may have COVID-19, you need to self-quarantine, here is your counseling. The downgrading, this has been a big challenge because if you are in a higher level of care, then the lower level of care providers may be less familiar or more comfortable with this patient that you're sending to them. I think some of the strategies I've seen adopted is allowing like ward doctors or junior doctors to round on the patients in the higher level of care prior to downgrading so they understand what has happened, what the progression is and the patient courses. I think when you're downgrading from PUI or ILI to non-PUI ILI, you have to be extremely certain that you are convinced this person does not need testing. This is where testing actually can be useful though, because the testing can allow you to identify who should get the negative pressure rooms and who shouldn't, but it can also help you identify who is not COVID so they can go into the general patient population pool as well. I suggest that, COVID, really what I've learned is about good clinical management. Less is more. There's no magic bullet yet. And that you should treat these patients the same way you would treat any patient with acute respiratory failure or pneumonia. And good clinical management, being vigilant, and then doing what is appropriate for your clinical care pathway at your institution.
So I think I'm going to stop the questions there. We had more of them, but we're at 9:45 and we want to get you some rest because you've just been talking for 45 minutes. So if there are any last words you'd like to say, and then I'll just wrap up with some minor housekeeping.
Okay, so thank you everybody for logging in and for taking the time to listen to this series. We do have some really exciting topics coming up, so keep an eye on the website. If you want to contribute, right, of your experiences that you're facing in your countries, we would welcome you to do your own session, because we do want to have a stronger LMIC voice within these sessions, and we are trying to invite partners to come onto the sessions with us. And if you have any feedback or if there's any lingering questions, email me, email Hopkins Center for Global Health. We will post questions back on the website, and if I get a lot of questions, I'll attempt to do a Q&A session within the next couple of days.
Yeah, that's exactly right. So any questions we didn't get to today, we'll make sure that we get to answer them and put them on our resource page. Our next session is on Thursday morning, so please join us if you can. And otherwise, I think we have all of your information from the registration page, so we'll be reaching out as well. Thank you everyone for joining us today. And again, we'll see you soon, I hope. Thank you, Bhakti, so much for your time and effort today. Please go rest.
Going to bed. I'm proning.